Okay, giant cell arteritis. The clinical picture can be very obvious in the step 2 stems. However, in real life practice, you have to have a keen eye. First of all, the age of these patients are more than or equal to 50 years old, and these patients usually present with some sort of new headache with some associated malaise, and they will have an elevated ESR or erythrocyte sedimentation rate. Other very common features will include fever, jaw claudication, and tenderness over the temporal artery. Giant cell arteritis is highly associated with polymyalgia rheumatica, which is characterized itself by achy pains and stiffness to the proximal shoulder and even the hip girdles. Although it's common enough, remember that almost half your patients will not present with this polymyalgia rheumatica picture. Typically, your patients will present with vision loss, and if GCA is left untreated, it can result in permanent vision loss. This is due to ischemic optic neuropathy. The standard initial treatment for these patients is high dose or intermediate oral glucocorticoids, typically prednisone, maybe 40 to 60 milligrams every day. Those patients with early ocular symptoms and not permanent vision loss, remember this is amaurosis fugax or vision blurring, and these patients have to be admitted in the hospital urgently. They have to have a pulse dose of parenteral glucocorticoids, a very high dose of methylprednisolone, maybe 500 to 1,000 milligrams daily. Patients who actually end up having giant cell arteritis will require a very long-term course of glucocorticoid therapy, so it's very important to get the temporal artery biopsy as soon as possible. Don't wait to get the biopsy in order to start the treatment. Just start it right away. It's okay to start the treatment before the biopsy. You will still have detectable GCA findings up to 30 days after even starting initial treatment. When these patients come in because they have a headache picture, don't choose non-contrast CT right away just because you're suspecting some type of intracranial bleeding, such as a subarachnoid hemorrhage. Remember that a subarachnoid hemorrhage, yes, it will present with a severe thunderclap headache classically, and subdural and epidural hematomas will occur in the setting of some type of trauma. But if the patient has elevated ESR, this is way more consistent with GCA. Now, what if the patient has an elevated inflammatory marker like ESR or CRP, but they don't have any headache or temporal artery tenderness? Well, then this can be just an isolated polymyalgia rheumatica, and you can treat this with glucocorticoids without any other workup. You really don't need to get the temporal artery biopsy, but if they have a headache and temporal artery tenderness, then give them the high dose glucocorticoids and then also order a temporal artery biopsy.